All right, guys, we're back. What up, Philippe? How are you?
How are you?
Oh, my life's calmer than your life, homie.
It's actually my life is pretty calm now too, luckily.
Oh,
So
good.
yeah.
A couple weeks ago, it wasn't so calm, though, right?
No, the couple weeks ago was pretty crazy, man. It was I was working every day almost, and it was wild. It was like I woke up in a nightmare. So
What was it like? First of all, what was it like just being in New York, right? Like, because, at first when all this popped off with coronavirus in the US, like, it was Washington State, right? I think Colorado at one point was ahead of New York as far as the caseload.
yeah,
And then, like, to me, I remember thinking, like, how is it even possible that like that these big cities, especially LA and New York, on the coasts where people come, and then all of a sudden New York went fucking nuts.
yeah. It was like I felt like it was a sucker punch, man.
Right.
We at the hospital were getting like word of what type of strategic plan administration was having meetings with us about what our new assignments might be, and if an outbreak were to happen, and it pretty much, like, New York in general, it went from, actually I remember the weekend, March 12th, that was, I think, like a Friday or Saturday. That was my fiance's birthday.
So March 12th was a Thursday because we closed the schools on Friday, March 13th, man. Friday the 13th. So go ahead.
Yeah. Okay. Oh, that was that. So my fiance's birthday was on the 12th, and we had a party scheduled for her on that Saturday.
All right, on the 14th. Yep. Go ahead.
Yeah, yeah. And it was supposed to be like a big surprise thing, and I had 50 people coming to a karaoke spot, like, in the city. It was supposed to be, and everything just started canceling. Like, people were backing out, and next thing you know, the place calls me and says, like, we're closing, and I'm like, what is happening?
Right.
So, and then by that, like, Monday or Tuesday, I remember it was like, all right, we're just gonna be pretty much like on lockdown, and that definitely hit us pretty hard.
Right. But then you had to work, so you weren't really locked down, right?
Yeah.
You are an ER nurse, right?
Yeah, well, originally an ER nurse, but I work in cardiac cath now for the last 10 years in cardiac cath. So.
Right. So, I think one of the things that people are misunderstanding, possibly, is that, like, you hear, like, the layoffs going on in the hospital, right? Like, a lot of people got furloughed, nurses, techs, and all that stuff. But that's because to work in the ER, and correct me if I'm wrong, so they shut everything down because they have to be ready for ventilators and beds and all this stuff. Yeah. And if you're a nurse on a regular floor, you can't just go work in the ER. Go ahead.
No. Well, there's so with the corona pandemic, there are two locations that would be where I would call it more of like the front lines of the situation. Obviously, the ER is the primary location, and then the ICU and isolation units. So the level of care is especially if you have to come to the hospital and you have coronavirus and you're having like real serious symptoms, you would likely need an ICU level bed, and that's like a limited capacity. Even some of the major hospitals in the city have only 20 beds. So, and we're talking about we were preparing for hundreds of people requiring ICU level care, and that also takes a level of training and years of training for nurses and physicians. So intensivists, doctors, and critical care nurses, you just can't kind of pull them out and say, hey, you're a critical care nurse. There's a lot of stuff involved in that level care, as well as in the ER too. So, but the other parts of the hospital were getting shut down. So there's a lot of diagnostic things like endoscopies, elective surgeries. You might have cancer removal, tumors, knee replacements. All this stuff has to be shut down for a period of time to take in the patients who need isolation and need corona level care. But and also if you're going into the hospital and you're going to have an elective procedure done, you might not want to come in particularly because you might get exposed. You might go in there for a knee surgery and you leave with corona,
Right. So my wife's a nurse practitioner, right?
Yeah.
And she's a hospitalist. So she does the rounding on the patients.
Yeah.
And for a couple weeks here, there was no one in the hospital. She was like, she would go to work and have like 4 patients and she'd be like, yeah, where are all the heart attacks? Right? Yeah. Where are the strokes? Because like people just stayed at home with a heart attack. They were like, I'm not fucking going. I'll ride this shit out.
Yeah. I don't want to get the coronas.
It's like it was great. She said it was nuts. Like she's like, how did coronavirus stop heart attacks? But I mean, it didn't stop heart attacks. They just wouldn't come to the hospital. Yeah,
a lot of people, especially they were in fear of coming to the hospital. In the last few weeks, though, I would say the last 2 weeks, we're getting a more regular set of patients. We're actually opening up the cath lab. We're doing procedures that were waiting from a few months ago, and now they're doing them. And also, we are doing some critical patients that might have been pushed just a couple of weeks, but we really need to get them done. So we're opening up those things right now. So.
Good. So things are getting back to normal in New York a little bit.
Yeah, things are getting back to normal. We're still a little tricky with the level of care after procedures. So like if you go to the OR or if you go to the cath lab, like where are you going to recover? Because a lot of our hospital units are still converted to isolation, COVID isolation. So you might not want to recover in a unit where a patient next room is a corona patient. So that's an issue that a lot of hospitals are having, but they are slowly turning back and flipping units back to their regular dedicated level of care that they were originally assigned for, and not corona. So, but they do like thorough cleanings. I've seen different units where they shut them down. They have this like spray that's it's pretty serious. So.
My another one of my friends, it's his wife, and she's our friend too. They both train jiu-jitsu. She works in a psych ward, and they just had an outbreak in the psych ward. A couple of people got it, and she's like, it's impossible to control because these people are crazy, right? And you can't keep them in their room. Right? Like they get, like they're just all over the psych ward touching everything. And you're like, yeah, like she's like watching it. She's saying, and she's like, what the fuck's going on? Like, and they don't have all the PPE in the psych ward, right? They just have a mask and she's like, oh, fuck. And now it's, right? Because, and you can't,
that's a recipe for disaster.
Yeah, because you can't say, she says you can't sedate them either, because then that will slow the respiratory. And then they could die of the corona, right? And it's like, she's like, this is a nightmare.
Oh man, that's tough, man. Yeah, I have a friend who's also in psych, and he actually got corona, and he was out for a few weeks. He's a young guy. He's an athlete too, so he's okay. But like, where did he get it from? He obviously probably got it from a patient, coughing him. It's pretty crazy, man. It's pretty crazy.
Take us through a day in the life, of your life, like, on the worst, like in the middle of that chaos, right?
So
like, what was that like?
I would say the toughest days were, cause I was deployed to 2 areas. I was in the ER. That we had a dedicated spot in the ER where we pretty much had only COVID patients. It was double doored, sealed area. And that was like my dedicated spot, and we would rotate. We'd do like 6 hour. I would do a 12-hour shift usually. So I would do half the shift in that unit with my PPE on. And it's like, it melts your face, man, when you're wearing N95 mask, or I have this crazy respirator mask that I bought, and I could reuse it. It's a P100 and it has these special filters. So it was tough. But besides the ER, I was on this thing called Rapid Response, which is pretty much like a mobile code unit. So because they they needed to open up beds for critical care throughout the hospital. They converted a lot of units that weren't critical care to ICU level care, and the staff there might not have been thoroughly trained for ICU level care. So, and we pretty much just had like a hodgepodge together, like put together units that were ICU level care, but it really wasn't dedicated for that. So you had to have this mobile staff run around the hospital checking and rounding on all these critical care patients. So myself and some anesthesia team, we call it the respiratory. We even had a team called the prone team, which is a team where we would have to flip. It's really weird because one of the things we did is we have to flip patients upside down. I don't know if you ever
laying on their bellies, right? You're saying?
Yeah, laying on their belly. So we had a team dedicated to this, as well as being part of the code team. So in one day, I'll be running around and doing like 20 codes. Codes meaning like patients could be in full cardiac arrest, meaning their heart can have an arrhythmia and require CPR, or respiratory arrest where their saturations are pretty much dwindling between 70% or lower, or sometimes even lower than that. And we would.
Can you explain that to people? What that's like what a normal saturation should be like, and
sure, yeah. So
and then what 90 feels like.
Yeah, exactly. So like 90 would mean you would probably be like, if you did like a sprint and you were sipping through a straw, maybe your sat would go down to 90. So, like that's like huffing and puffing and you could hardly get the air in. So,
right.
So you and I probably have sats of, 95 to 100%. That's your normal saturation. That's the level of oxygen that your hemoglobin can carry in a normal human being, in a healthy human being. And, that's what we carry on a normal basis. So these patients, if you are pretty much like slowly suffocating, which is what these patients were experiencing, they wouldn't be able to get this oxygen exchange in their lungs. Their lungs are just so shot that no matter how hard they're breathing, the oxygen exchange didn't happen. So their saturations would drop to the 80s. And the 80s actually was almost an okay, acceptable number. So
So sprinting, laying on the ground, gasping for air is 90, right?
Yeah. Yeah. For us. That's
for us. And 80's cool.
80s for these patients, patients who are like critical. Now we don't just intubate patients. So I would be on this team and we would assess patients.
Intubate meaning put a ventilator in them.
Yeah, put a tube down their throat and allow a breathing machine to breathe for them. That would be like the very last resort. I know the president and our governor Cuomo was all about these ventilators, and I could see where he's coming from, and I could see where medical staff is coming from, because this is a last resort. But before you get to invasive level respirations, you want to try everything else. So we do high flow oxygen, which is pretty much like a nasal cannula, and we connect it to a machine where we would also supply some water into the high flow so they can like pound their lungs with this high flow oxygen. We put non-rebreather mask, which is like a mask with a bag that has 100% oxygen blowing. So you really want the last resort to be invasive. And then before that, we would do this thing called BiPAP. I don't know if you've seen people who snore, they wear this like suction cup thing around their face.
Yeah, CPAP.
Yeah. So we would have that level machine available before we would try all these non-invasive things first. And then last resort, we would escalate to a ventilator.
Because, correct me if I'm wrong here, most people that went on the vent died.
Absolutely. The percentages are horrible.
Right.
If you require a ventilator, it's likely, I'm not sure about, what other hospitals are, but I've heard anywhere between like 90% chance or greater that you are not going to be, you're not going to live past the ventilator. You will never be able to, breathe on your own. So,
right.
Yeah. So,
which is not normally the case, right? That's rather abnormal. Normally, when we vent people, right? When you guys vent people,
yes,
they recover, they build back up, and then here they are, still functioning in the world. So the ventilator is a very good thing in a normal day in the hospital.
Yeah, absolutely, absolutely. So, and that would be my day. I would run around with the team. I would get paged with the team and be running around from room to room to room, checking proning patients, checking their saturations, and then and then either escalating to different levels of respiratory care, and then also transferring patients from higher levels of care. I remember maybe in one day I must have had maybe about 8 to 10 deaths. I mean, that's pretty significant. There are times where we didn't even have enough body bags on the floor that we were working on. So this was, coming from a ER background and coming, as an athlete and a fighter, I'm pretty tough with not getting an emotional situation. But I was definitely there a few weeks ago and felt, man, this is like a super tough thing to deal with. And I see it in my coworkers' faces. The saddest thing is too, just seeing patients who, and you can't have any family members. So I would see patients, on their phones and that, telling their family member, all right, I'm about to get intubated. I can't breathe right now. And they're huffing and puffing, they're sweating, and they're, and their family members on the other line, crying and screaming. And I'm like, in my head, listen, in my head is like, this is the last conversation that you're likely going to talk to your husband.
This is it.
This is it. So to witness that, oh my God, that was like, I would go home and be like, damn, that sucks, man. Oh my God.
And what was the age of the people sometimes?
Yes, I would say, the majority were, I would say the ones I witnessed, about 50s, 60s and older. There were a few though that were younger. I've seen 30-year-olds and one 20-year-old that actually died from this. So that is like really, really heartfelt and unexpected, and a lot of people ask about the comorbidities. Most of them have a lot of comorbidities. So I would say, especially the older ones, they have a lot of comorbidities. The American population is not as healthy. So we had patients that were overweight, obese. We have patients that just have simple things too, maybe high blood pressure, diabetes. Those are very high risk to get sick from this. But I've also seen that very, very rare where they have like no issue at all and they get it and need to get intubated. It's
the no issue seemed to be that what's the hypoxic storm? What's it called? When your immune system goes over the top, right?
Yeah, I mean, I'm not sure how the process is. We're still studying it, and it's funny. Another thing is this was like a learning process for the medical staff and the nursing staff. We're like, all right, we're going to give hydrochloroquine. We're going to give this. We're going to give that. All right, we're going to do Pepsid with this and mix, and we're going to prone patients. And so it was like we're learning as we go, and we're trying our best. So
I think that's part of the problem for the people, right? Is okay, so we already have a big enough problem in the country, I believe, of almost too much information. Like you whatever you would like to believe, you will find that and scientific articles on the internet. Like there's a flat earth movement right now, backed by science, right? Backed by science,
Oh my gosh, this is, yeah.
So what would you like to find on the internet? And go ahead. Right? You will find it. It's like porn, right? If whatever you're into, it's yours, baby. Somebody else has filmed it already.
Yeah, whatever deep hole you want to get into.
So this idea of the doctors being wrong. Yeah. Well, yeah, of course they're wrong. We don't know. This came up in November of last year. right?
Yeah.
Like,
so there's pretty much a study. I mean, there's research behind it, but it's not long enough to know what the real results will be.
right.
You know, there was the Gilead study on remdesivir reduces hospital stay by, I think, a few days. That's a good study. I mean, that was like a legitimate study. But we need more potent information here. And studies take years to develop, and here we were just hit, and it's pretty crazy. Also, the fact of having these patients intubated, there's a lot of research and people debating about not intubating because it causes such high pressure in the lungs, which could actually destroy the lungs tissue,
right.
because it's called like the PEEP end expiratory pressure. So it's like they would force all this air in, and that's why they would die. So it's like we don't really know what formula we're going by just yet. So
just and I'm lucky enough that my wife, and my friends, I have a bunch of great friends that are ER docs too. So normally when you intubate somebody, you put them on a pressure, very low pressure, like a 2.
Yeah.
Right? A 2.
Yeah.
When you're intubating these COVID patients, it's like a 12, a 10, which is like unheard of.
Yeah, you need to keep the alveoli open, because you don't want them to collapse. That's how the lung tissue. So we put this PEEP pressure like 10, 15 or more, and then what happens is when you try to wean them off the vent, they can't breathe on their own. So they wound up, that's what happens. Their lungs never recover. The lungs just get so pounded that they never recover.
Right. So like the whole ventilator thing was very difficult, right? Like we were talking about before. And again, like when you're talking about like hydrochloroquine, I don't know if I said that right, whatever, and whatever else, like when you give medicines, you want to know what happens 3 weeks later sometimes.
Yes, absolutely.
And we don't have that process going on, because how could we? Yeah,
it's a difficult thing. I know the hydrochloroquine, it's used for patients with lupus, and I think there's some research regarding malaria. If patients who are on hydrochloroquine, persistently for long term, what's their ability, if they could get corona, and how, there's all this stuff, but it takes months and months and years to know this. So it's pretty wild.
I think we've moved off the hydrochloroquine, right? No one's really doing that much anymore, right? Like
I actually in the last 2 weeks I haven't been in COVID level care, so I'm not sure how they do it. I'm gonna go up and ask, but
sure.
It's still, I think it's still being used, because I gave it to a lot of patients a few weeks ago. So,
so like you said, in the last 2 weeks, you haven't been on COVID level care.
No, the only time I would be in a specific COVID level care is if the patient. We've had patients who have heart attacks, and they have to come to the cath lab, and we have to put stents in them. So then I would have to put. You have, a double whammy. So the patients have COVID. They might not be they're COVID positive, but they might not be on a ventilator or be critical from the COVID, but they also happen to have a heart attack. So now I'm protecting myself. I'm wearing my PPE, and so is the whole unit. So.
Right. All right, let's talk about that for a second, because you hear all this like, oh, people are dying from stuff other than COVID. COVID can be like HIV, correct? Or AIDS, where you have COVID, and correct me if I'm wrong, and then explain more. And then like you develop pneumonia because of the COVID, and you die of pneumonia, right?
Yes.
So go ahead, explain.
So what's exactly killing people? You like HIV, you have HIV, but then you might die from pneumonia too. You might die from a few different things. What we also notice, a lot of these patients who have COVID, they're in a hypercoagulated state, which is really weird. It's these patients have their blood is actually coagulating quicker than normal people. Now, I don't know if it could be just because you're in the hospital.
Can you explain coagulated? What does that mean?
So that means like if you were to bleed, like if you were to have a cut on your skin or something on your body required coagulation, like a scab. So they would just coagulate faster. So
coagulate meaning clot.
Clot, yeah.
Okay,
your blood would clot faster. So we've noticed that patients who are critical COVID patients, they have like a really fast clotting cascade. So that's very serious because you're at risk for heart attacks, strokes, pulmonary embolisms, all these things. A pretty serious effect. So you might have not the pneumonia kill you, you might have a heart attack that kills you, you might have a pulmonary embolism that can kill you and have COVID. So
but that was caused by the COVID.
It's very possible. Now,
right. Yeah, we don't know.
So we don't really know, but there are definitely studies coming out that will show this information, and I've seen it firsthand. And now what the treatment is that we have to really anticoagulate these patients when they're in the hospital. We give them a lot of heparin, prophylactically to prevent this from happening. I've seen a lot of COVID patients with DVTs, which is a deep vein thrombosis. Like if you're pretty much sitting too long, or if you're in an airplane, you ever see where they tell you have to get up, walk around, and because it's a risk for a DVT. Well, a lot of these patients who are COVID are getting these DVTs, and then it migrates to your lung and gives you a pulmonary embolism. So it's pretty serious with that. So we don't really know, and I don't know what the linkage is between this virus and causing this clotting cascade to pick up. So
right.
Yeah, we don't really know what's killing people,
So it's super interesting because you see, like again, everyone trying to talk about COVID. And like, oh, that wasn't really a COVID death, or oh, that was a COVID death, or oh, they're doing like we just don't know. Why can't we just sit in some? It's so hard for us to sit in some unknown, right? Like we want to say that that person's lying or this person's lying. It's crazy to me.
Oh, I've seen
it's so crazy to me.
Yeah, and I've seen things about. Now I haven't talked to hospital billing and stuff, but I've seen some things about. Oh, if you say the patient had COVID and they died, we get like extra money. I don't know. Whenever there's money behind things get very, very tricky. So, but I do think that there are, a patient might have COVID and they can be, they could die from something that's either related or unrelated. But now the patient had COVID, so it's up to the doctor what cause of death, I guess, they would put.
Right. But like you said, you have moved back to your normal station, right? Your normal unit.
Yeah.
So what is a day in the life in New York City look like right now?
Yeah, so I haven't really been out. I'm getting like stir crazy myself, and so are my coworkers. So like a day in the life in New York, the only times I would say I go out is for a jog. I get my fiance and I, we go for walks and stuff. I wear a mask. I know there's like this movement of like not wearing a mask. I'm a healthcare provider and I'm in it. So I don't want to spread this to anybody. God forbid I'm a carrier, but everything's closed. But as the weather gets better, people go out, I ride my bike, but it's pretty sad seeing the businesses and places that I know might not open up.
Right.
New York, I love the mom and pop style places, and that's what America's about too. And I see them suffering. I have friends who own businesses, and I see how they're suffering. I don't know how long this is going to go for. And I as a healthcare provider who's seen it, and also now I see a downtick in the hospital, I really think that it could be a smart move to slowly open up things. I know the country is slowly opening up, but I think even here in New York, we might be able to open up. Very little reasonable things should open up.
Excuse me.
I don't want to overdo it. You know.
Right. Man, I had one of my friends, like I said, is an ER doc, and his podcast episode aired today. He talked about rather than this idea of pushing a switch on and pushing a switch off, a dimmer, right?
Yeah.
Like where, like, hey, just dim the lights on a little bit,
Yeah.
right? And then, okay, dim them on a little more. Yeah, you know.
Yes, exactly. Because ultimately, we're going to be exposed. Little by little, we're going to be exposed, and what the whole quarantine thing was to prevent a healthcare crash.
Right.
Like that's why that's why the hospitals prepared in such a way. Their hospitals with like tents outside. They had the Navy ship come to New York City. It didn't really require that entire Navy ship. That was like if a shit hits the fan type of situation. But we've seen it. It didn't happen. We were prepared, and it's very good to be prepared. And, now I think it might be time to start trickling in, at least let the healthy people come out, keeping a respectable distance. If you're a restaurant, I think that, can have this 25%, max capacity thing, separate the tables. Like these businesses, we got to open up again. New York, and we've been hit hard, but how I see how the hospital is, I think we can open up, not like we were months ago, but little by little.
Right. Yeah, I think some of the misconception too is that people think that this whole thing was so that to stop you and I from getting COVID. And I don't think that's true, right? It was to stop you and me and our neighbors and our neighbors' neighbors and everyone in the whole world and the whole country from getting COVID at the same time.
Yeah, exactly.
Right.
Now, exactly. We want to flatten the curve, like instead of having the curve go straight up like this,
right?
It was going to be like a slow process. So,
and then stay here though.
Yeah.
Right.
Yeah,
like do this and then stay right here underneath the level of what the healthcare facility can take care of. Not do this, not fall off.
Yeah. We don't want people like lining up in front of the ER and dying in the street. Like that would be horrific.
You don't want to choose that guy or that guy for a ventilator.
Yeah. And we were actually, what was crazy a few weeks ago or a month ago, we were, we had those meetings at work. Hey, this is the level of care. We have to prioritize. It's a war, and we're going to prioritize. If we have this, we're going to prioritize the ventilator is for this person because they have the best life expectancy, the least comorbidities, and likely survive. So we actually had these meetings. I have friends in other hospitals who in administration had these meetings. And that was scary.
Did you have to make that? Did you guys ever have to make that decision? Were you ever there?
No, it never got to that decision. So, luckily not. Good. But we were definitely brought to the point where we had a systematic approach to it, like a documented systematic approach where it said, these are the levels that you're going to have to take to make a decision if this patient needs it and this patient, and then how you quantify which person's going to get the ventilator and get the best care and the other ones are going to die. Like
that's a terrible decision.
Yeah. And I don't want to be responsible for that. And I don't know if I want to be a part of that team, but this is what we were looking at. Luckily, it hasn't happened. Not that I witnessed. I'm not saying it hasn't happened in general, but I haven't witnessed.
You just hadn't seen it, right? So
I haven't. So and I luckily I was tested for COVID twice. So luckily I'm negative. I did the nasal swab.
Does that hurt? So, it looks bad.
Oh man, it's like they swabbed my brain. Oh my God, it was bad. So
yeah.
And then I actually got an antibody test about a week ago, and it's weird. I had an antibody test where it said I had a super small amount of antibodies, where it's like a 0.05, and anything above 1.1 means you have enough antibodies, but I guess mine is like super low. So it's questionable if I had a mild exposure or not. It's so low to that level, but
we still don't know what the antibodies. Everyone's banking on these antibodies, and we still don't know what the antibodies mean, right?
We don't even know. Yeah, exactly. We don't. It's
because you can have antibodies. You know, you can have antibodies. You build antibodies to the flu, and then you still got to get a flu shot the next year.
Exactly.
Right? You can get flu A every year. It's possible, right?
Yes.
Like it's not like you get flu A 1 year and then you never get flu A again. Like Like
absolutely.
And maybe and for some people the vaccine works forever. It's just unknown, right?
It is.
It's unknown. So coronavirus could be just like that, right? Like when we come up with a vaccine, are you going to need the vaccine every year? Are you going to need it every 3 years, every 3 months, right? Like it's a difficult thing, the medical.
Yeah, it's super tricky. We know for sure that influenza itself mutates like crazy,
right?
All the time. Yeah, this is like one of the most That's why the flu is like we get these vaccines every year for influenza, for the seasonal flu. But now with this, we're talking about it might strike back, in the fall or every year. Imagine if this happens. I mean, this will be, our lives might not be the same. It likely won't be the same, not for many years.
Yeah, it's gonna suck. But it will just be, we'll have to deal.
Yeah.
So look, man, you and I both do jiu-jitsu, right?
Absolutely.
We you're on Nogueira's team, but Ultimate Fighter vets, right?
Yeah, brother.
When are we gonna and I don't know, do you think it's different per location? Right? Like, like when Henzo's is going to open up again in like the middle of downtown Manhattan, and when am I going to open up again in Boulder, Colorado? Are they different times? Are they the same times in your opinion? What do you think?
I would say you have a better chance of opening up sooner. I hope Henzo's opens, but that's going to be tough.
Right.
I would say you have a better chance of opening up sooner, this is the toughest thing, because as a jiu-jitsu practitioner myself, and I am absolutely in love with the sport, this is the most contact you're going to get with anybody.
Oh yeah, with the antithesis of social distancing.
Yeah, this is like we're literally sweating on top of each other. This is the one sport.
Your sweat drips in my mouth because you're.
Yeah, dude, this is crazy. I mean, boxing and kickboxing, you can get away with a little bit. Like, all right, we could shadow box.
Right.
We're literally on top of each other. So this is, and I miss training so much. Oh my God. I know guys are training and it's cool, man. As long as they're training with each other and, and I mean, they're young. And if they want to take the risk, they could take the risk. And I just don't want to do it, because I'm exposed to this stuff all the time, and I don't want to.
You're in a hospital 5 days a week, homie.
Yeah.
I'm sorry.
If anyone gets sick, they're gonna fucking say it's Nover, man.
Yeah.
Nover good with that
and
shit.
They'll never know, but they'll be like, "You fucking killed my father," right?
Yeah. Oh my God, I wouldn't be able to live with myself, man. So I've been practicing the social distancing with jiu-jitsu, man. But I really hope we can open up soon. I have a lot of friends too who have small gyms out there. I think Henzo's will be okay. Will be fine. There's going to be a lot of smaller gyms that might have not the biggest population of people who are into jiu-jitsu. And also now you got to be pretty hardcore into jiu-jitsu at least to continue training. I really hope that people continue training and this is going to be tough.
Yeah. We're going to see what happens. I think we're going to be all right.
Good.
I think we're going to be all right. I think we're going to open. I hope that we can open sometime in June out here.
Okay.
So that would be nice.
Absolutely, man. I wish you the best, man.
Man.
It's
you could never imagine this day, bro. You could never imagine this day.
Yeah.
Right? Like,
no.
like I've been saying, you can imagine like a downturn, like the economy, you know, like, and you go, okay, you know, and I have enough money saved for here and there, you know, like,
Yeah.
but you can't imagine a screeching halt.
Yeah. It's like shit. It's like a reset button. Like,
Full,
like everything's just shut down.
Shut down. Open fully one day and closed, like out of business the next. Like, you know, you're like, whoa, what the fuck?
Yeah. This just sucker punch completely, man.
Yeah, man.
Yeah.
Well, bro, I appreciate your time, you know. Thank you for what you're doing, right? Like, it's the front lines, homie, right? Like it's the front lines of something that we don't know, that is very risky for everyone, right? You have family, you have, like you said, a fiance that you're coming home to. So like, it's not just your risk, it's your loved one's risks. It's a lot of people's risks. So, man, thank you very much, man. First of all, for doing it. And then second of all, for explaining it, trying to help explain it to everyone, you know?
Thanks, man. Thanks for having me, man.
Yeah.
I miss you, man. We're going to train when we get through this. You're a little bigger than me and a lot better than me too. So don't crush me. Man. I'm going to be really rusty when I come back to training.
We'll be good, man. I'm 40. Hopefully I'll turn 40 here in a month, you know, or two.
No way.
Yeah, man. I'm old, bro. I'm old and rusty, you know? Yeah, man.
You look young, man.
You know, it's just because I shave my head and you can't see where the hair doesn't grow.
No, man, you're a young, healthy guy, man.
Yeah, man. So, and hopefully we both stay that way, right? Well, not young, right? Because like you either get old or die young. So I'm hoping for the get old path.
Get old, yeah.
Yeah. So
be healthy at the same time.
All right, man. Thank you very much, bro.